and in the end, we placed 7 coils into my pelvic veins via the jugular vein in my neck.
I don't think this is going to be one of them where it's like, rip it off fast and just get it over and done with, because I don't know what's going on under here, so I have to be a bit more mindful.
If it leaks a little bit, it's 1. If it leaks a lot, it's 2. And if it's gross, it's 3. That's the highest you can get. And you've got 3 out of 3 for all 3 veins. So it certainly looks like you've got pelvic congestion syndrome here.
Jennie Jacques discussing scan results with Professor Mark Whiteley. Starting from the top and working our way down, let's begin with the arms.
You have a very, very significant change in your flow rates in your arms. That's called thoracic outlet syndrome. We're seeing that it is actually affecting your peak systolic velocities here. When you're just at rest, the blood flow is fine. But as soon as you start trying to move your arms, you're actually getting pinching of your blood vessels. Highly suggested that you do have thoracic outlet syndrome. The classic symptom for this is when you're trying to comb your hair and your arms feel tired. A lot of people think, am I just unfit? What's going on? It's actually the fact that you're interrupting your blood supply because your muscles going into your first rib are lifting it up. As you lift your arm, it's part of the way you brace your shoulders, and that can pinch these blood vessels further. So it's a bit like a long-term smoker who can't walk because they've got narrowing in their leg arteries, and so they're fine at rest, but when they start walking, they get pain in their legs, and that's called claudication. There's not enough blood supply for the extra effort, and it's the same with thoracic outlet syndrome, but in your case, it looks like it's actually because you're getting claudication of your arms.
Claudication is the body saying, I can't get enough blood or oxygen where it's needed.
It's not one of the things I treat. We diagnose it. There are some absolute experts who treat this, and it usually is checking with another test to make 100% sure they're happy before they operate. And it can be done either with a fusion operation. It's usually done above the clavicle up here. Nowadays, a man called Roos, who's very famous in America, invented a technique, the ROOS, where they actually go under the arm. You're sneaking up between the chest wall and the blood vessels. In this way, you're going under the blood vessels to clear the obstruction. So it's a bit of a deep, dark hole to do that operation, but that's where more and more of the experts are doing it. But that's a highly specialized area. So I'll have to find someone for you for that.
Wow, yeah, it's a hell of a lot to take in, but obviously very validating. My partner's been washing my hair for a long time. As much as it's washing the hair or combing, it's actually, for me, sometimes doing stuff just with my arms without it necessarily being right up here.
But the basics of this is very interesting. So if you look at a skeleton and you take away this perception you've got of these arms and shoulders being broad, the rib cage comes up and there's only a very small hole at the top. And yet everything, it's why, when you hear about throat injuries, people cutting the throat and stuff, it's so dangerous. Up here is very, very, it's all your major structures, your arteries to your brain, veins going back down, thoracic outlet, your esophagus, your windpipe for breathing trachea, your esophagus for food. Everything's got to pass through that tiny little hole there. So anything at all that narrows that is going to be a problem. And you can have this thing, we can have an extra rib that could be calcified, or sometimes just a band, which you can't see with x-rays, that just tense everything up a bit more, especially if it goes back down your arms. Now, on top of that, you've then got this clavicle going across, which is holding your shoulder and shoulder blade out there. And the scapula, the shoulder blade, is just in a sea of muscle. The only thing that connects your arm to your chest is this one bone called the clavicle. And that's why if you break it, your arm drops. But that bloating area there, all of those blood vessels and everything have to go down into the arm in that little area. So not surprising if you've got perfect anatomy and everything's working well, no problem. But the slightest kink, because there's an extra bit of band or something over the top, suddenly can mean that even the strangest movements can worsen this. And sometimes it's even just putting a rucksack on. You can actually be pulling that down and it can just actually pinch as the blood vessel comes out of the chest and goes into it. You can just, that little tiny pinch is enough to actually block the blood vessel. If it blocks the vein at the front, you can get thromboses, you get DVTs in the arm. If it's the artery behind, you get this thing called claudication. If it's on the nerve, it's much harder to diagnose as well, because the nerve has to have blood supply to stay alive, and pressure on a nerve, sometimes it means ow at that point, but that's rare. It's most important. You get these weird feelings down your arm, sometimes numbness, sometimes just complete and utter feeling of, I've got no power at all. That combined with the artery as well, it will give you really strange feelings whenever that's pinched. And you've got not only a strong history for that, but you've also got a very strong finding. So away from everything else we've discovered, your thoracic outlet syndrome seems to be moderate to severe. So you need to see someone who is well versed in thoracic outlet syndrome for the arm side, without doubt. from what we're expert in, you've got good going pelvic congestion syndrome, and that's varicose veins in the pelvis. So you definitely got reflux in your left ovarian vein and both internal iliac veins, which is the most common cause of pelvic congestion. And you've got great big reflux, left ovarian, both internal. The way we score it is when you do what's called a Kegel move or Valsalva, when you do the strain like that, blood shouldn't go down the veins. If it leaks a little bit, it's 1. If it leaks a lot, it's 2. And if it's gross, it's 3. That's the highest you can get. And you've got 3 out of 3 for all 3 veins. If all of your veins were the worst they can be, it's 12. One of your veins is working, the other 3 aren't. So the maximum you can have to go around is 9. And when we score it, when you're straining, it's 9 out of 9. And when you're at rest, it's still 7 out of 9. The best test in the world is the transvaginal duplex with the Holdstock-Harrison protocol, what you had, which is 45 degrees. The trouble with like MRIs and CTs, as we said before, when you're lying flat, you can't see this reflux and everything looks a bit squashed. So they overdiagnose narrowings, May-Thurner syndrome and nutcracker. So these things are massively overdiagnosed. You need to have these functional tests where you actually see the blood flowing and you can measure them, such as you've had. And that shows very clearly you've got no narrowings that anyone can see, but you do have functional at least, and but you do definitely have this reflux. It certainly looks like you've got pelvic congestion syndrome here. They thought it might be narrowed, and there's an awful lot of people in the world who are having stents put into what's called May-Thurner syndrome, because on ultrasound they look narrowed, but in fact they went ahead and had the air plethysmography, which actually measures flow, shows absolutely no sign of any May-Thurner syndrome at all. When your legs are lifted up, blood rushes out. But on these results, it'd be totally erroneous to put a stent into this.
Nutcracker syndrome and May-Thurner syndrome are often overdiagnosed. As Professor Whiteley rightly points out, stenting isn't something to rush into. It's a lifelong commitment, and if misapplied, it comes with real risks. What matters most is careful investigation and personalised treatment. For some patients, yes, a stent may be the right call. For others, targeted embolization is enough. Professor Whiteley is a leading vascular surgeon with deep expertise. I genuinely recommend anyone dealing with similar issues read his book and, if possible, seek assessment through the Whiteley Clinic.
There's mild reflux just seen on the left leg. So that stasis on the right side does actually show up even on this test. There's a little bit of reflux. So left leg's normal limit. So that's what stasis is. It's sort of like borderline. It's sort of saying there might be a problem in the future rather than there's a problem now. As far as classic duplex is concerned, you don't have major reflux in either this side, which is your right side. You've got a little bit more on your left side. But what's really interesting is when the sonographers look at the legs, although in most of your veins, the blood is shooting up when you move and when they squeeze you, the one big vein called the great venous vein, you've got this thing called stasis. So the blood that should be shooting up to your heart, usually we diagnose varicose veins when the valves don't work and blood falls down with gravity. We're finding that in a proportion of people, though, if it's got nowhere to go, in other words, there's no varicose veins, it's just the valves are failing, it just sits there and it's called venous stasis. And you can also get venous stasis in smaller veins as well. But this is sort of one of these areas where duplex is not the greatest test in the world, but it's one of the best we've got.
Okay, I think obviously we need to discuss the treatment of my pelvics. And is this something that once I show my GP, I can go through the NHS, or is it only private? And the same goes for the thoracic outlet syndrome. And the other question, how can we get more people diagnosed? How does this all work?
Thoracic outlet syndrome. So there tends to be an NHS route for that. I can't say that for sure, but certainly when I used to work in the NHS, there was a route for that. The problem with veins is there is no job in the NHS for consultant vein surgeon or consultant phlebotomist. And because there's no job for it, there's therefore no training for it. There is also then no medical school training. So what happens is several of my research fellows have gone through, when they finish their training, they come back and say to me, it's amazing, in the whole of my 5 years training, I had 1 hour on varicose veins and leg ulcers. Whereas those of us in the veins world, of course, we have whole conferences looking at the nuances of different, not only varicose veins, but the fact, the latest research coming out showing we've known for a long time that your quality of life is decreased dramatically if you don't fix veins in the legs, because they can go on to cause swelling, they can go on to cause aching, as we know, but more importantly, you can start to get fractional cutaneous damage and inflammation. And there's a paper recently from PLOS One, it's a online journal, showing that in fact you've got an increased risk of Alzheimer's disease if you've got varicose veins, which seems to be reversed if you have them treated. And there's a lot of cardiovascular treatment. There's a leader in the Lancet recently pointing out that actually if you've got varicose veins and they're not fixed and they get worse, it's associated with early death from heart attack and stroke. And the suggestion is it's a bit like anything else that's chronic inflammatory in the body. We now know, there's a lot of people talking about chronic inflammation in the aesthetics world, talking about, what diet do I have? Because that's very sexy and everyone likes talking about diet. But the reality is one of the biggest things you can do is get rid of any source of inflammation. The big source of inflammation used to be like things like stomach ulcers. And we know that when people used to have stomach ulcers, they were they had a much higher risk of heart attack and stroke, because it basically causes inflammation, which thickens the blood. You get more fibrinogen, you get it clogs up the little arteries around your heart, around your brain. And this seems to be the same case for varicose veins, because you've got this great big area of inflammation in the lower legs. So the difficulty is we've got, countless years where the governments in the past and private health insurance companies have said, well, varicose veins are only cosmetic. So therefore, there's been very little research in the UK, very little training. And you can see that because most people in the UK, they only look for reflux in the two major veins, the great venous and the smallest venous. And I'm writing a book at the moment about the sort of things to be wary of when you go to see someone who says they do veins, because they're usually an artery surgeon or a vascular surgeon, or they're a radiologist or a general surgeon. So they're not trained in veins specifically. It's just something you do on the side. And as such, they just treat the two main veins rather than 150 veins that can cause varicose veins. And that's why people say all the time, oh, varicose veins always come back. It's not that they come back. It's that usually they're not treating all of the veins that cause the problem in the first place. Of course, the next thing, varicose veins is a big hobby horse, but we've published lots on that. More and more English doctors are trying to sort of look along that route. But what most aren't even bothering is the pelvic vein. So people get told they've got endometriosis, PCOS, etc. Whereas in fact, if you ask the gynecologist and a lot of these women who've got pelvic pain, did they have big veins at laparoscopy? They say, oh yeah, they've all got them. And they're seeing the pelvic congestion. They're just not being trained to say, actually, that's the problem. So almost all the literature in it is from the venous world, from around the world. And luckily, the Whiteley Clinic is a leading centre in the world for that. But in the UK, there's been some recent publications showing how few even vein surgeons have any understanding of it all. One thing that is important to note, though, there is a big divide for those of us who are at the leading edge of the pelvic and abdominal veins. If you read the American literature in particular, there are not all, but quite a few centres, and it's now coming to the UK a bit more, where they're talking about compression syndromes all the time. And yet, if you do proper tests, in fact, compression syndromes are very rare for these conditions. And there's a lot of people having stents put in for incorrect reasons. And we've had a couple of patients who have had the left kidney removed when they shouldn't have had it removed. Almost definitely they got told they had a thing called nutcracker syndrome, and they had no improvement whatsoever having had their left kidney removed. Another one as well, being told they've got May-Thurner syndrome, being told they must have a stent. And when they came along and had the test that we gave to you, it turns out their veins are completely open. If you lie the patient flat and do what's called IVUS, like intravascular ultrasound or MRI, it looks like it's narrowed, but if you stress it, it's not narrowed at all. So the difficulty with that is, in the veins world, I'm afraid there isn't an NHS route through to having quality veins. And when I was back in the NHS back before 2007, I was told that the only way I could stay in the NHS is if I stopped doing veins, and because they wanted us to do arteries. And in the words of my chief executive officer of the country chief executive of the hospital I was in, he just said, our business plan is not to do veins. If you do veins, you have to leave. And he gave me a 6-month sabbatical to go and decide what I wanted to do. So the reality is there is very little groundbreaking work and very little route through for complex vein work in the NHS at the moment in the UK.
And how can we change that?
Well, I write books on it. I've written a book on leg ulcers and how the English taxpayer has paid for the Everos study and the Eshgar study, saying that if you've got a leg ulcer, very, very commonly due to varicose veins or hidden varicose veins, if we just treated them, people could actually get back to normal work and their leg ulcer would disappear. But instead, even though the taxpayer paid for that, it's published by English authors and then randomized control studies in England, most patients are still sent to district nurses for bandaging, and they're not given an ultrasound scan. They're not found, and nobody's treating them. And there've been a few sewings now starting, and I published a book, Leg Ulcer Treatment Revolution, which actually highlights this. And that's way before we even get to pelvic veins. So I published a book in 2019 about the pelvic vein side, and we still know that the majority of gynecologists still don't recognize it, ignore it. Yet the patients don't come to vein surgeons for pelvic pain, because obviously it's pelvic pain. You think it would be a gynecologist. Now, if the gynecologist says, well, we've looked at everything, it must be endometriosis, it must be your or something like that, you're going to trust them. At the moment, it's only those people who've been suffering for a very long time who go on the internet and suddenly find out this thing called pelvic congestion, find out the gynecologists aren't recognizing it or looking for it, and then find places like our clinic where we've actually published so much research in the past. People realize we do know what we're talking about. We published a paper recently, and we showed that the most happy people after pelvic congestion are those who took 9 years or more to diagnose. But how horrendous that you've almost a decade of having to be in pain before someone diagnoses you. And that's purely and simply, if you go on the Royal College of Obstetrician and Gynecologists website and look up the causes of pelvic pain, there's a green paper and it lists all the ones that they look for, and veins aren't in there. Pelvic congestion is not there.
As someone who is diagnosed with ME after a viral infection, and there's a lot of us, unfortunately, just how horrendous this isn't really shocking me. Obviously, because I've had to live with an ME diagnosis for 7 years. But the fact it's been 7 years and I've pretty much, in many ways, masked or hidden the pain so that I don't come across as hysterical or a bit crazy or them saying it's all in my head, it really has been and is unbearable. And now having these scan results, obviously I can talk about it a little bit more freely and on behalf of others. I think my concern is if this links to ME as much as I think it could, and if you take the work of, say, Dr. Stephen Smith that shows these overlaps, and obviously there needs to be much more funding for the science to, really prove anything, then that's, in a way, another pandemic of its own, isn't it? In a way, could be a way to fix very many people who have these, I've been calling them compression syndromes. I did notice in what you were saying to me, and I may have misunderstood, that maybe the pelvic congestion, the pelvic insufficiency isn't a compression syndrome, but thoracic is. How do you differentiate between them? Because I'm a bit confused.
So compression syndrome means that the veins or the structures are being compressed. In the thoracic outlet, it is compression because the vessels are being compressed between the first rib or the band and the muscles around it. Most of the varicose veins in the pelvis and the legs are not compression syndromes, they're valve failure and stasis. And a lot of doctors have got this weird idea that if you've got pelvic congestion, it must be compression. So these veins have only got big because there's an outflow obstruction. There's basically compression, so blood has to find another way. Yet those same doctors are quite happy to ablate varicose veins in the legs. They don't look for a compression there. So they sort of turn around, and if it's in the legs, oh yeah, well, the valves are failing. But the next vein up, oh no, well, it must be something pushing on it to make it big, which is just rubbish because all the veins react more or less the same way below the heart. And what our studies have shown that in our series, only about 1% of people with pelvic congestion have any hint of compression at all, maximum 2%. But there are papers from the United States saying it's like 46% or 48%. And what they're doing is they're using MRI or CT or IVUS. They lie the patient flat. And when if you're lying flat and not moving, the veins will quite often look compressed because one thing pushing on them, there's no pressure to hold them open. Whereas if you go for a walk and you're standing upright, of course, there's no compression at all. So it's not a real compression. It's a pseudo-compression. It only appears there because of the way you're doing the imaging. Recently, I've just had a lovely young lady who saw a surgeon in London for her horrible leg varicose veins, worse on the right than the left, with some skin discoloration around the right, clearly needs it done. And he tried to persuade her that she had May-Thurner syndrome, which is a compression of the left iliac vein, and was trying to persuade her, she's in her late 20s, was trying to persuade her to have a stent put in to open this up. Whereas when you actually do a proper test with an epismography, she's got no obstruction there at all. And that lady, if she had listened to that advice, would have ended up with a stent in her veins, not only costing her money, but then if that stent, because it's not being held in place, because there's nothing really wrong, that could end up in her heart or lungs. But more importantly, it irritates the vein. And over the next decade or two, she'd have to have continual scans to see if it's still open. And it's not even needed. And that's the sort of problems we're starting to see in the veins world by people who are launching into veins, especially companies who know there's money to be earned in it, etc. And this is acceptable because it's in a paper written by an enthusiast. And they're not thinking logically about what is the best for the patient in front of them. Going back to what what you're saying as well about the ME. I think the difficulty with ME is because we don't have a test for ME itself. I mean, there is the Marshall Protocol, and there's very interesting work on the vitamin Ds and, whether you're looking at the right sort of vitamin D, etc., and how it's being tested. So there's very interesting immunological work, which isn't my area of expertise, although I'm interested in it. But I think, unfortunately, people who have chronic fatigue or ME often have their symptoms written off and not investigated. So people such as yourself who actually have a diagnosis of something that could be fixed, it gets wrapped up in other symptoms. That way, the things that can be fixed already are ignored or not even diagnosed. It all gets lumped in together for you, and you end up suffering for things that actually you could suffer a lot less if those ones were picked off and treated individually. It's a very bad problem. I mean, I think once somebody gets the label of a chronic illness, a lot of doctors just switch off.
Yeah, it's also hard being female. I hide that I'm an actress because I don't want them to, ironically, I'm putting on an act to try and act like I'm better than I am, to try and make them take me seriously. It's like the complete other way around. I've had sneers and looks at the fact I'm using a stick, and I explain the pain in my pelvis, and it's a bit like, then they talk about the mind-body connection with pain, etc. And the same with the upper body, and it gets to a point where you just stop saying it.
Well, the thing is, you've got two proven now. We've got two proven causes, one for your arm and upper body pain and one for your pelvic pain. You've got physical things that can be treated, and you poor girl, you've got both of them together. You've actually got two curable conditions that would probably take away an awful lot of your symptoms.
Yeah, and I think both of those conditions, if not one of them, might be within a lot of people with an ME diagnosis, potentially. And I do think that blood flow could be at the core for a lot of people. It could be part of the Rubik's Cube. It's just not being diagnosed. People take 9 years to get to you.
I think before somebody diagnoses you with ME, they should actually exclude all the actual other causes. Because imagine if you had these two conditions treated and suddenly you had either no symptoms or only 1% or 2% of the symptoms you've been suffering from. How angry would you be? You actually haven't had the problems treated. Now, it might be it's only 50%. It might be whatever. But the thing is, the worry is once you get that label, people stop looking for curable conditions. It just makes a horrible life. Whereas if you could take away those pains and get it better, you'd actually be able to then really focus on the last things that are left to improve. That's when you would know if these other treatments you're doing will be working on the ME, because at the moment, a lot of improvement will be masked because you've got pelvic congestion syndrome, you've got thoracic outlet syndrome.
Absolutely. And look, I am seeing improvement by targeting the infections, but I'm still a shadow of my former self, and I'm still in a hell of a lot of pain, hence why I was so eager to get seen by you. A key way to diagnose ME is post-exertional malaise, and it's really specific. You do an activity and 12 to 24 hours later, you can be really severely disabled, and I'm talking bedridden for a long time. It can be a few days, it can be a few hours, it can be weeks.
PEM is a core symptom of ME, and it refers to this worsening of symptoms after even minor physical, mental, or emotional exertion, the kind of activity that would not have caused any problem before the illness. Even at the milder end of the spectrum, I can still really struggle. Something as seemingly simple as taking a phone call can leave me extraordinarily drained and symptomatic. Symptoms may worsen hours or even a day or two after the activity. For some people, the delay can be even longer. PEM can be horrifically severe, completely out of proportion to the effort made. A crash, in inverted commas, can last for weeks, days, or even longer. Tragically, for some, a crash can become permanent, leading to long-term or irreversible deterioration. I don't have enough time to fully explain PEM, but I hope that you can gauge from this. It's an absolute monster of an illness. For some people with ME, just the simple task of survival, breathing, eating, drinking can have dire consequences. We have got to fund the science, and we have got to get to the bottom of this tragic illness.
If my blood's not getting around my body properly, is there something in me recovering from some sort of activity, mild exertion, or just trying to digest food? Is there something that could disable me that badly from having these? I'm trying to connect the dots.
Not simply, and I'm not an expert in ME and chronic fatigue. I have a great respect of the Marshall Protocol and his ideas, and I do think that when we're looking at the immunological system, that's very interesting what he's done.
The Marshall Protocol was developed by Dr. Trevor Marshall in the early 2000s. It targets chronic conditions like ME/CFS and Lyme disease. My understanding is it focuses on restricting vitamin D, using antibiotics to address intercellular bacteria, and modulating the immune system. I am not promoting or criticizing this protocol, as I don't know enough about it. However, my current treatment with Professor Jack Lambert does share some similarities. It includes antibiotics, antivirals, and low-dose naltrexone, though unlike the Marshall Protocol, we do not alter my vitamin D levels. As many of you already know, I am not a doctor. This is not medical advice, and always consult a trusted healthcare provider to determine the best treatment plan for you.
It's a bit like sort of having flu and a broken ankle. We know broken ankles, we know how to fix that. Let's fix that, sort that out, and then we can look at the flu, which is viral. Do you take some drugs out now, as you know, for flus, and there's other things. You've got to turn around and say, right, what is it we can fix first? What is it that's good? And then see what you're left with afterwards. Go very sorry for you, because you have got two absolutely good diagnoses for chronic pain, and they haven't been diagnosed. And yet you do the right tests, and lo and behold, you got them. And then once those are fixed and you've got over the usual post-operative recovery, then you'll start reassessing, what am I feeling like now I've got rid of those two pains?
I sort of saw it like the plumbing in a house.
Although we've always thought of vascular surgery, we've only ever thought of it as plumbing. This new research coming out showing that the chronic inflammation then has effects on the blood, which then affects heart, brain. I mean, it's not going to be long before they also find it affects the thyroid, it affects the pancreas. Suddenly then can understand how these things can be systemic.
This is why I was saying about the ME diagnosis. On a cellular level, I do believe that these plumbing issues, in inverted commas, have really caused me cellular hell.
My chief theory is this chronic inflammation. All the pains you're getting are causing chronic inflammation, which will be causing all sorts of factors in your blood. The latest things that are now coming out in the venous world are mimicking what was found in a lot of other places, such as stomach ulcers with H. pylori about 20 years ago. And we're suddenly realizing that this chronic inflammation in one area of the body actually has systemic effect. The association with POTS as well. I don't fully understand that, because that's obviously not inflammatory, but there is, without doubt, a lot of people who have pelvic congestion also have POTS. There's a really good, clear correlation with that. So, I mean, there's huge amounts we have to still learn. There's the one side which is academically interesting. There's the other side, of course, is how do we treat the patients in front of us? If we correct your thoracic outlet syndrome and we correct your pelvis, we need you to go for 6 to 9 months afterwards and see how you're improving, and then see what position we're in, and hope you're in an awful lot better position at that stage. Am I right?
All right. Thank you so much. You've been absolutely amazing. Thank you.
No, but lovely speaking to you again.
Bye.
Bye-bye there.
Before we finish, I want to mention something that might be helpful for anyone diagnosed and considering this procedure privately. A company called Chrysalis Finance offers a range of payment options, subject to credit checks and approval. You can find out all the information on their website, chrysalisfinance.co.uk. As for my own experience with pelvic vein embolization, I'll be sharing updates once I've had enough time to properly recover and reflect on the results. I'll do so as responsibly and honestly as I can. But because of my ME, I do understand recovery could take up to 12 or even 18 months. It was actually as exciting as it was uncomfortable, and thank God it was horizontal, else I wouldn't have been able to do it. Professor Beckett was fantastic.
This is sort of a secondary, sort of what we call a microcatheter, which can actually go inside the main catheter, and we can navigate this smaller catheter into place and then place a very fine coil through that.
And in the end, we placed 7 coils into my pelvic veins via the jugular vein in my neck.
And then this is the catheter that we're going to use to basically place the coils where we want to get down to. Some people feel a fluttering in the heart, that is normal. Okay.
I actually enjoyed being awake to see it all unfold, or should I say, uncoil?